It is usually seen with chip drugs. S goes for sulfonamide. H goes for hydralazine. I goes for anti-tubercular drug, and that is isoniazid. I goes for, and P goes for procainamide. It is an anti-arrhythmic drug, guys, procainamide. And if they ask you the most common drug leading to drug-induced SLE, the answer should be procainamide. Most common drug causing SLE would be procainamide. No issues with this, anybody? Now, which are the antibodies seen in cases of drug-induced SLE? It is anti-histone antibodies. Which antibodies are seen in drug-induced SLE? Now, please let me know, drug-induced SLE would be severe clinically or mild clinically? It would be clinically mild. Why? Because please remember, in cases of drug-induced SLE, lupus cerebritis or lupus nephritis are not seen, as renal manifestations or brain manifestations are not seen. Therefore, drug-induced SLE would be clinically mild in nature. Okay, no issues with this. Now, important SLE, if I talk about systemic lupus erythematosus, guys, it is an autoimmune condition, as all of us know, right? And autoimmune conditions usually are more common in which sex? They are more common in females. Rather, in SLE, the female is to male ratio is almost 9:1. Okay, so 9 females are affected in comparison to 1 male, right? So please remember, SLE is mainly a female predominant disease. Yaad rakhna ye. Okay, we'll discuss about the antibodies later. First, I'll talk about the clinical symptoms. And the clinical symptoms, as I've uploaded in the video also, they can be remembered with this mnemonic: boss are mad. Okay? So B goes for brain manifestation. And which is the most common brain manifestation in SLE? Anybody? Lupus cerebritis is a very severe manifestation. It is not the most common one, right? So most common one is cognition defects. Most common brain manifestation is lupus cerebritis is only seen when there would be anti-neuronal antibodies, okay, or anti-glutamate receptor antibodies. Only in the later or severe forms of SLE we can see lupus cerebritis. Usually the most common would be cognition defects. O goes for oral aphthous ulcers. O goes for. So these oral aphthous ulcers, these would be recurrent in nature. They would almost come every month in the patient, right? Apart from that, these would be painless or painful. Mainly these are painless ulcers. So which type of ulcers are seen in SLE patients? Oral aphthous ulcers, which are recurrent in nature and painless. Okay? S goes for serositis. S goes for inflammation of the serous cavities. Like the pleural cavity, there would be pleuritis. Pericardial cavity, there would be pericarditis. Okay? So please remember, most common lung manifestation, pleuritis. Most common lung manifestation, most common heart manifestation. Apart from this, we have also seen in cases of SLE, one more heart manifestation is seen, but it is very least common rather. Okay, it is inflammation of the endocardium. That means endocarditis. And which endocarditis is seen in SLE patient? It is known as Liebman-Sachs endocarditis. Okay, which endocarditis is seen in SLE? Which endocarditis is seen? Liebman-Sachs endocarditis. Important, right? And in Liebman-Sachs endocarditis, as we know, there is vegetations which are formed. These are sterile vegetations present on the heart valve. These vegetations are mainly present on which surface of valve? Upper, lateral, under, commissural end. They can be present anywhere, but predominantly On the under surface of the valve, predominantly on the under surface of valve. Why it is important? Because if they are present on the under surface of valve, they will also damage the chordae tendineae. It will also damage the chordae tendineae, and that can cause mitral regurgitation. That would lead to mitral. समझ गए? याद रखना. So least common heart manifestation, if they ask you answer, is Liebman Sachs endocarditis. Vegetations in Liebman Sachs are usually predominantly seen on which surface? Under surface, and they will dominate which structures? Chordae tendineae, and that will cause which valvular region? Mitral regurgitation. It will cause mitral regurgitation. No issues with this. Next test stands for Synovitis. So as I told you earlier also, in SLE now, Harrison does not say it as arthritis. Why? Because if we call it arthritis, it should be associated with deformities. But in SLE, usually deformities are not seen. Therefore, it is called as synovitis, inflammation of the synovium, right? Synovitis. And how many joints are involved? More than equal to 2 joints. How many joints are involved? 2 or more joints. How many joints are involved? How many joints are involved? How many joints are involved? These are mainly small joints or large joints? These can be any joint. Yaad rakhna, it is not a small or a large joint. It can either be a small joint like PIP, MCP, or it can be large joints like shoulder, ankle, or knee joint as well. Okay? So it is not associated only with either small or larger joints. Okay? We will discuss about small and larger joints later. And it is symmetric in nature or asymmetric in nature? It is asymmetric in nature. It can involve any. It can involve this PIP joint, and it can involve this knee joint. So it is very asymmetric in nature. Next, if I talk about, guys, A goes for alopecia. A for alopecia seen in SLE is scarring or non-scarring? It is a non-scarring alopecia. It is a, so alopecia seen in SLE is a, alopecia or hair loss seen in SLE is a non-scarring alopecia, right? Important. Then R goes for, I'll write it over here. R goes for renal manifestation. R goes for renal manifestation. And renal manifestations, there would be lupus, nephritis. There would be lupus, right? So if SLE may there is renal manifestations or there is renal involvement, it is called as lupus nephritis. The patient can be asymptomatic in the earlier stages, but in the later stages, the patient can develop hypertension, there would be hematuria, and there would be proteinuria. So nephrotic syndrome-like features only. Hypertension, hematuria, and proteinuria would be seen in this patient, right? If I talk about the biopsy of lupus nephritis, we discussed it. Which type of lesions are seen in kidneys? Very good. Which type of lesions? Which type of lesion? In which condition? Lupus nephritis. Now, there are almost 6 classes of lupus nephritis, okay? According to the involvement of the glomerulus, it is classified into 6 classes. Important, yaad rakh lo bas, the most common class or the most common type would be type 4. Most common type of lupus nephritis is type. Most common type of lupus nephritis is type. It is also called as diffuse lupus nephritis. It is also called as, that means more than 50% of the glomeruli are involved. Okay? This was a question recently I saw 1 or 2 times, so it is important. Most common type of lupus nephritis, type, and it is known as diffuse lupus nephritis. No issues with this, anybody? Next. E goes for extremities, guys. Okay? E stands for extremities. On extremities, as in cases of SLE, not only the RBCs are damaged, not only the WBCs are damaged, but along with that, platelets are also damaged. So if platelets are damaged, the value of platelets will go down. And if platelets value goes down, it is called as thrombocytopenia. And there would be which manifestation? Petechiae would be seen. What would be seen on extremities? What is seen on extremities? Petechiae. No issues till here. We are done with R. Then M. M goes for this butterfly or the malar rash. M goes for the butterfly or the, N goes for the, and it is feature. That means it will exacerbate or increase when it is exposed, when the patient is exposed to sunlight. No issues with this. Then A goes for anemia in this patient. A goes for now in SLE we can see anemia of chronic disease as well as autoimmune hemolytic anemia. Out of this, which would be more common? More commoner would be anemia of chronic disease. Okay, as we know that SLE usually is a long-term or chronic illness. Therefore, anemia of chronic disease is seen, right? So, SLE में most common type of anemia is anemia of chronic disease. I hope all of you are quite aware. Anemia of chronic disease can be normocytic, normochromic. It can be microcytic, hypochromic. But more commonly it is normocytic, normochromic. So in SLE also, normocytic, normochromic anemia of chronic disease is seen. No issues here. Autoimmune hemolytic anemia क्यों दिखता है? As we know, SLE is a autoimmune disease. So what are found inside the body? Auto antibodies. So these antibodies will not only attack the platelet, it will also attack the WBCs. So there can be leukopenia in the patient. It will also attack the RBCs mainly. So anti-erythrocyte antibodies would be seen, and that will cause an autoimmune hemolytic anemia in the patient, right? But it is not much common. Okay? If I talk about the peripheral blood smear of autoimmune hemolytic anemia, what can be seen? Very good. We can see spirocytes. So this is the normal RBC you can see over here. A normal RBC will have a central 1/3 pallor. Normal RBC has a central 1/3 pallor, right? But a spirocyte, if it's seen, spirocyte would not have any central 1/3 pallor. It would be completely red in color. So if a completely red RBC is seen, that is called as which cell? That is called as a spirocyte. So spirocyte most of us see in a child on a peripheral blood smear. Then it is diagnostic of hereditary spirocytosis. Yaad rakhna, if I can find a spirocyte on a 2-year-old child's peripheral blood smear, then I think in terms of hereditary spirocytosis. But I find these spirocytes on a peripheral blood smear of a young adult female, 19, 20, 25-year-old female having SLE manifestations. I will definitely think in terms of autoimmune hemolytic anemia. Okay? So spirocytes are seen in 2 conditions. In childhood mein, and in adulthood, autoimmune hemolytic anemia. No issues with this. Along with this, here you can see the RBCs are almost stuck to each other. Okay, and when RBCs stick to each other, this is called as agglutination. Okay, when RBCs stick to each other, it is called as. So agglutination is a feature of autoimmune hemolytic anemia. We will also discuss about Rolex formation. I'll tell you afterwards. Okay? And what is the investigation of choice for autoimmune hemolytic anemia? Direct Coombs test. Investigation of choice for autoimmune hemolytic anemia is? Direct Coombs test. Indirect Coombs test is used for RH incompatibility. And lastly, D stands for a discoid rash. Discoid rash. Discoid rash is actually a circular rash with a dark periphery and a light center. Okay, this kind of a rash you have seen in an SLE patient. It is called as a discoid rash. So if butterfly rash is not given, this type of a rash can also be given. Okay, both of them are photosensitive. So अगर वो नहीं है, इसका मतलब ये नहीं कि the patient does not have SLE. You need to look also for the other features which are there, right? Now I'll talk about the antibodies. Most important part because it is an autoimmune condition. Now please tell me the most sensitive antibody would be? Most sensitive antibody is anti-nuclear antibody. Most sensitive antibody Most sensitive antibody, anti-nuclear. ठीक है, याद रख लेना. Please remember, sensitive में N आता है ना, मैंने तो ऐसे याद रखा हुआ. Why it is most sensitive? So please remember, it would be very non-specific. It is also seen in all the other autoimmune conditions like rheumatoid arthritis, systemic sclerosis, Sjogren's syndrome. Everywhere AN is positive. Okay, so it is most sensitive, but not the specific one. If I ask you about the most specific antibody, the answer would be anti-Smith antibody. Most specific is, and most sensitive is ANA. Most sensitive is, no issues with this, anti-nuclear antibody. Then please tell me which antibody will tell me about the disease activity or disease progression. Right, it is anti-double-stranded DNA antibody. So which antibody tells me about the disease activity? Anti-DS-DNA bolo. Which antibody tells me about the disease activity? Which antibody tells me about the disease activity? Which antibody tells me about the disease progression? Anti-DS-DNA antibody. No issues with this now? Important. Then, which antibody is responsible for photosensitivity? Antibody responsible for photosensitivity is anti-Rho antibody. Antibody responsible for photosensitivity is anti-Rho antibody, also called as SSA antibody. Please remember, anti-Rho antibody, apart from photosensitivity, it can also be a cause of neonatal lupus. So if a SLE patient is pregnant, so now what can happen? This anti-Rho antibody, as it is IgG type, therefore it can cross the placenta and it can damage the fetus. And in child, we can find neonatal lupus. We can see neonatal. So if a newborn presents to you with butterfly rash or malar rash, along with features of severe bradycardia and complete heart block, the diagnosis is neonatal lupus. Then the diagnosis is, so please remember, neonatal lupus is characterized by complete heart block in the patient, which will lead to severe bradycardia, and along with the malar or butterfly rash would be present in the child. Okay, no issues with this. This malar rash in this child would not only be over here. Image mein yahan bhi aa sakta hai. Periorbital rash can also be present. So look for the other features also. Okay, please remember this. So anti-Rho antibody is responsible for two important conditions. First is, and second is neonatal lupus. No issues with this. As I told you, anti-neuronal antibody can be a cause of lupus cerebritis in the patient. Anti-erythrocyte will cause autoimmune hemolytic anemia in the patient. किसी को और extra as याद रखना है तो anti-ribosomal P antibody causes neuropsychiatric manifestation. Anti-ribosomal P antibody causes neuropsychiatric manifestations in the patient. No issues till here, I hope so. Now for diagnosis of SLE, guys, please remember, for diagnosis of SLE, how many features should be present? At least 4. How many features are required? Minimum 4 features are required. Out of this, one should be a lab feature. One should be a clinical feature. So how many features are required in minimum? 4. Out of that, one should be lab and the other should be clinical. So 1 lab, 3 clinical, or 3 lab, 1 clinical. Okay, by lab I mean all the antibodies which are seen. Okay, no issues with this now. Please tell me the drug of choice for SLE. Drug of choice for SLE, it is an autoimmune condition. The answer would be steroids. But as we know, steroids are not given in cases of SLE in pregnancy. The reason not being because it would the patient is already immunocompromised. The answer is actually the steroids are inactivated by the placental enzyme and therefore it is of no use. Therefore, in pregnancy, the drug of choice would be hydroxychloroquine. Pregnancy, the drug of choice for SLE would be, pregnancy mein drug of choice for SLE is hydroxychloroquine in the patient. No issues with this, I hope so. Now please tell me which is the most common cause of death in cases of SLE. Most common cause of death in SLE in the early decades. In early decades it is infection. Or if a patient is on treatment, also the most common cause of death would be infection, because steroids would lead to immunocompromised state. Sorry. Okay? So most common cause of death in SLE in the early decade, undergoing treatment. If I say most common cause of death in active SLE, then the answer would be lupus nephritis. Then the answer would be, so most common cause of death in active SLE, most common cause of death in active SLE, and most common cause of death after 45 years of age, accelerated atherosclerosis. Most common cause of death after 45 years of age, atherosclerosis. No issues till here. Done with SLE. Moving further. Now, a young patient comes to you. Okay, a young female who is between 25 to 55 years of age group. Young female between 25 to 55 years of age group, and presents to you with such deformities. Here you can see there are some deformities in the hand. Okay, so if deformities are present, along with that, the patient will complain to you of joint pain. Okay, the patient will complain to you of joint pain. The more likely diagnosis would be, the diagnosis is rheumatoid arthritis. So rheumatoid arthritis is common in which sex? Rheumatoid arthritis is common in which sex? In which age group? In which age group? Most common complaint would be joint pain. Now this joint pain would involve large joints or smaller joints? It will involve mainly small joints. It would be symmetrical or asymmetrical? It would be bilaterally symmetrical. I'll explain. See, in rheumatoid arthritis, usually the patient will complain of pain in the PIP joint or the MCP joint, wrist joint, right? So these small joints are involved and they are bilaterally symmetrical. That means the patient will complain of pain in both the PIP joint, both the MCP joint, both the wrist joint. Okay? So this is called as bilaterally symmetrical small joint involvement is seen in cases of rheumatoid arthritis in the patient. No issues till here. Now, the patient will also complain that after getting up in the morning, the patient is not able to move, or there is a rigidness or a stiffness which she feels. So this is called as morning stiffness. Morning stiffness in rheumatoid arthritis lasts for more than 1 hour. Morning stiffness in rheumatoid arthritis lasts for more than, in ankylosing spondylitis, it usually lasts for 30 minutes. It usually lasts for, but here it will last for 1 to 2 hours usually. Here it will last for 1 to 2 hours. No issues with this. And the patient will say that this stiffness usually improves on rest or activity. It improves on activity. So this morning stiffness improves on. So these are the characteristic words जो question में दे रहे होंगे. ठीक है? So the patient complains of bilateral small joint pain along with morning stiffness for 1 to 2 hours, which improves on physical activity. The diagnosis to be made if it is a young female is definitely rheumatoid arthritis in the patient, right? Rheumatoid arthritis, as it is erosive arthritis, so it will lead to damage of the cartilage. It can cause osteoporosis, and therefore it can also lead to deformities in the patient. Therefore, it will also cause deformities in the patient, right? SLE mein there was non-erosive arthritis. Here it is a erosive arthritis, and therefore we can find deformities in the patient. This characteristic picture had come many times, the upper one. Okay, here you can see in the thumb there is a which deformity in the thumb? Which deformity is seen in thumb? Which deformity is seen in thumb? Z-line deformity. Then if you see there is flexion at the PIP joint and hyperextension at the DIP joint. So it looks like a neck. It is known as the swan neck deformity. Flexion at PIP and hyperextension at DIP. Swan neck mein flexion is at the DIP joint. Flexion is at the, and hyperextension is at the hyperextension at the and flexion at the, it is called as. Then vice versa, if flexion is seen at the PIP joint, flexion at the PIP joint and hyperextension at the DIP joint, this is called as mountaineer deformity. This is called as, no issues with this. So two deformities. Flexion se yaad rakh lo. Flexion at the PIP joint it is. Flexion at the PIP joint it is. Flexion at PIP joint it is. Flexion at PIP joint it is. Mountaineer. Flexion at PIP joint it is. Flexion at PIP joint it is. Flexion at DIP joint it is. Flexion at DIP joint it is. No issues with this. Mnemonic अगर चाहिए तो PEP mnemonic याद रख लो. Okay. Flexion at PIP, extension at DIP, mountaineer's deformity. ठीक है? Then which joint is not involved in cases of rheumatoid arthritis? ये सबको पता होगा. So please remember, DIP joint is never involved in cases of rheumatoid arthritis. DIP joint is never involved in cases of rheumatoid arthritis. Now, apart from joint manifestation, or apart from joint pain, muscle pain, the patient will also complain of some extra-articular manifestation. So the most common extra-articular manifestation is rheumatoid nodules. Most common extra-articular manifestation is. So these rheumatoid nodules are subcutaneous. These are mainly present on the extensor, and these are non-tender. That means painless nodules. Okay? So most common extra-articular manifestation of rheumatoid arthritis. Most common extra-articular manifestation is rheumatoid nodules. This rheumatoid nodules would not only be present on the skin, it can be present in any organ. If it is present in lungs and if it ruptures, it can cause pleural effusion. Rheumatoid arthritis mein we discussed transudative or exudative pleural effusion is seen. Inflammatory conditions so exudative. So exudative pleural effusion is seen in cases of rheumatoid arthritis. Which type of pleural effusion is seen? Exudative pleural effusion. So the patient can also complain of breathlessness. Okay, all of that. Then, which is the most common eye manifestation? Anybody? Most common eye manifestation is keratoconjunctivitis sicca. Most common eye manifestation is, that means dryness of eyes. Most common eye manifestation is keratoconjunctivitis sicca. ये one liners है, ठीक है, याद कर लेना, important है. Apart from this, there would be other multiple manifestations, whichever system is involved. Okay, in eye also there are multiple other manifestations, but the most common one is keratoconjunctivitis sicca. Okay. Sorry. Now, keratoconjunctivitis sicca, dryness of mouth, dryness of eyes. Yes, definitely it is also seen in S-Jogren syndrome also. But S-Jogren syndrome में जो antibodies होती है ना, एक तो joint involvement नहीं होगी S-Jogren में, and secondly the antibodies would be different. Okay, so definitely confusion रहता है थोड़ा बहुत. But rheumatoid arthritis में eye manifestation is not the commonest one. But if in case eye is involved, then the most common manifestation would be keratoconjunctivitis sicca. Otherwise, the patient mainly complains of joint pain and all the joint related manifestations. Okay, no issues with this. So definitely the first line investigation would be X-ray or MRI. The first line would be in this patient's MRI. Why? Because if we perform an X-ray, on X-ray in early stages, no changes would be visible. Okay. On MRI, we can see some inflammatory changes, usually in the earlier stages. Okay. So MRI hand is done in the earlier stages of the disease, whereas in the late stages of disease, we can do a X-ray hand. And in X-ray, we can see reduced joint space. X-ray में क्या दिखेगा? X-ray में will see reduced joint space or periarticular osteoporosis can be seen. ठीक है? No issues with this. Now, please tell me the screening test of choice for rheumatoid arthritis. Causes. यूजुअली अगर हमें ये है ना, अगर फंगल वगैरह है तो यूजुअली डायरेक्टली स्क्रेपिंग्स वगैरह तो हम नहीं लेते. वी कैन स्टार्ट एंटीबायोटिक्स इन द पेशेंट इफ वी सस्पेक्ट. याद रखना, anyways if there is fungal infections or something like that, the patient will have predominantly signs. Symptoms would be very less. Signs are mostly predominant in cases of fungal keratitis or fungal corneal ulcers. ठीक है. Whereas in these cases the patient will only complain of dryness of eyes. इसके अलावा the patient would not have any other complaint. Neonatal में अगर होता है, usually the first line thing that you do is actually to rule out the causes. Okay, तो जो भी है, अगर female में, अगर patient में usually अगर उसकी mother में कोई autoimmune disease है, you will try to rule out that. If there is any infective causes, you try to rule out that. ठीक है, and accordingly, first is usually symptomatic management, and then you will try to investigate it. ठीक है, yeah. Screening test of choice in rheumatoid arthritis would be RA factor, rheumatoid arthritis factor. So if RA factor is positive, it is called as a seropositive arthritis. But if RA factor is negative, it would be called as a seronegative arthritis. If RA factor is negative, it is called as a seronegative arthritis. Okay? And what is the investigation of choice in this condition? Anti-CCP antibodies, that is anti-cyclic citrulline peptide antibodies. Which antibodies? Anti-cyclic citrulline peptide antibodies. So investigation of choice for rheumatoid arthritis, anti-CCP. Investigation of choice for rheumatoid arthritis, anti-CCP. Don't forget it. What is the drug of choice for rheumatoid arthritis, guys? Drug of choice are usually DMARDs. Drug of choice are usually disease-modifying anti-rheumatoid drugs. The most commonly used DMARD is methotrexate. Most commonly used DMARD is. So as we know, if a pregnant female comes to you with complaints of rheumatoid arthritis, definitely methotrexate cannot be given because it will kill the fetus. Therefore, in pregnancy, the drug of choice would be hydroxychloroquine. Pregnancy, the drug of choice would be. So pregnancy में DMARD of choice है. Otherwise, the DMARD of choice is methotrexate. If the patient is not responding to methotrexate alone, you can increase the dose of methotrexate and add other drugs like sulfasalazine in the patient. Okay, or even you can add some biologicals like certolizumab, abatacept. Okay, tofacitinib is the newer agent. So if they ask you which is the oral drug which can be given in cases of rheumatoid arthritis, answer is tofacitinib. Answer is. So which oral drug can be given in rheumatoid arthritis? Which oral drug can be given in case of rheumatoid arthritis? Tofacitinib. Pharma से बता रहा हूँ, it is a JAK3 inhibitor. नया है तो इसलिए पूछा जा सकता है. It is a JAK3 inhibitor, okay, and that oral drug which is given is tofacitinib. Moving further, now a middle-aged patient, okay, a middle-aged male presents to you now. A middle-aged male presents to you with pain and tenderness, pain, warmth, usually in which joint? In the first metatarsophalangeal joint or in the grade 2. First metatarsophalangeal joint of the grade 2. The diagnosis is more likely to be gout, and gout is due to increased levels of uric acid, that is hyperuricemia would be seen in this patient. And the most common involved joint is the first MTP joint. Most common involved joint is the which age group is common? Middle age group. Which age group is common? So 30 to 40-year-old male presenting to you with pain, inflammation at the first metatarsophalangeal joint. आँख बंद करके diagnosis can be gout. ठीक है, याद रख लेना. So here you can see inflammation, tenderness, warmth usually at the first MTP joint, right? Then like redness वगैरह होता है. Apart from this first MTP joint, a patient of osteoarthritis coming to you with redness and inflammation in the Bouchard's nose or the Heberdin's nose, that can also be a case of gout. Okay, so osteoarthritis ka patient if comes to you with extreme excruciating pain with inflammatory signs in the Bouchard or the Heberdin's nose. Bouchard's nodes are present at the PIP. Bouchard's nodes are present at the and Heberdin's nodes at the DIP joint. Heberdin's nodes at the, एक क्वेश्चन आ चुका है, कहाँ पे कौन सा होता है? तो बाउ चार्ट B पहले आता है, so PIP पे बाउ चार्ट notes and DIP पे Haberden's notes. If there is inflammatory finding in these notes, that can also be suggestive of gout. Sorry. What is the investigation of choice for gout, guys? Investigation of choice for gout is joint aspiration. Investigation of choice for gout is so you will aspirate the synovial fluid from the joint and then you will do a synovial fluid examination. On synovial fluid examination under polarized microscopy, which type of crystals? ये बता चुका हूँ मैं first class में. Positively or negatively birefringent? Negatively birefringent. Okay, negatively birefringent. Which shape? Needle-shaped crystals. Which shape? Needle-shaped crystals. And these crystals are made up of monosodium urate. These crystals are made up of. So please remember which type of crystals are seen in cases of gout? Monosodium. Which crystals are seen in cases of gout? Which crystals are seen in cases of gout? Under polarized microscopy they would be. Under polarized microscopy they would be. And which shaped crystal? Which shaped crystal? Needle shape. Positively birefringent rhomboid shaped crystals are calcium pyrophosphate crystals, a feature of pseudo gout. No issues with this. Moving further. Sorry. X-rays वगैरह भी ले सकते हो, but it would not be so much diagnostic. The investigation of choice is always joint aspiration in cases of gout. Okay. Now please tell me about the drugs. The drug of choice for gout. Definitely, if you need to analyze whether the patient is an overproducer or an under-excreter, then you need to do a urinary uric acid level. You will perform a urinary. So you will check the urinary uric acid levels for 24 hours. Based on that, you can come to a conclusion whether it is an overproducer or a under-excreter. So drug of choice for acute gout, please anybody? Drug of choice for acute gout are NSAID, non-steroidal anti-inflammatory drugs like indomethacin, ibuprofen, all of these. But if I say the patient has not been relieved on NSAID, then the next drug I can give are steroids. Direct kaha ja rahe. Then the next drugs are given are, and if the patient is not even improving on steroids, then the drug given is colchicine. Then the drug given is, the most effective drug in acute gout is, so it will inhibit inflammation in the patient, right? But the first line or the drug of choice for acute gout, NSAID. Not responsive then steroid. Not responsive then colchicine. Most effective drug, colchicine. If I talk about chronic gout, guys, so chalo, theek hai. Agar they only ask you the drug of choice for chronic gout, one answer can be allopurinol. But if they say that the patient is overproducer, then your answer would be allopurinol. If the patient is overproducer, the answer is overproducers by drug of choices. Okay, allopurinol. It will. Ye sarkari question. It will inhibit which enzyme? It will inhibit xanthine oxidase. It will inhibit which enzyme? Xanthine oxidase. And if the patient, allopurinol is renotoxic, it is nephrotoxic drug. Therefore, it is avoided in cases of renal failure. So, if the patient has renal failure, the other drug which can be given is febuxostat. The other drug which is given is, so drug of choice for overproducers in gout. But if the patient has renal failure, febuxostat. And if the patient is under-excreter, the drug of choice would be probenecid. The drug of choice is probenecid. ठीक है? Extra is ये MOK exams में आता है usually. So please remember, if the patient is not responding to any medical therapy, medically refractory gout, then the treatment would be a recombinant enzyme which is given, and that is known as pegloticase. IV pegloticase is given in cases of refractory gout, not responding to any therapy. We will give which drug? Pegloticase. Then 35-year-old That means again a young or a middle-aged female presenting to you with complaints of dysphagia. That means difficulty swallowing, color changes in the fingertips on cold exposure and skin tightening. So पहले तो ये बताओ, what is your provisional diagnosis? Scleroderma. These color changes they have said on cold exposure in the fingers, which we can see over here. So whenever the patient will have cold exposure, the patient can have these color changes. ये question और ये image बहुत बार आ चुकी है, ठीक है? So the patient will have these color changes. Okay, there would be extreme vasoconstriction leading to which color? White color. Then there would be accumulation of deoxyhemoglobin leading to which color? Blue color. And then there would be again vasodilation causing red color. So the sequence is WBR. Sequence भी पूछी जा चुकी है. The sequence of color change in Raynaud phenomena is sequence of color change in Raynaud phenomena is, so definitely this is called as your Raynaud phenomena. This is called as your Raynaud. What is the difference between Raynaud's phenomena and Raynaud's disease? This was a question. So please remember, Raynaud's disease is nothing but primary Raynaud's phenomena. Raynaud's disease is primary Raynaud's phenomena when the cause is idiopathic and it is not associated with any other condition. Okay? So primary idiopathic Raynaud's phenomena is called as Raynaud's disease. It is called as Raynaud's. Whereas secondary Raynaud's phenomena is associated with autoimmune conditions, like over here it is scleroderma. Okay? No issues with this? I hope so. Now, the patient have also mentioned about skin tightening. And skin tightening, this was the last year question, December question. So they have only given this kind of image. Similar image was seen. There was redness on the skin. Okay, this is nothing but skin induration. This is nothing but skin induration. Along with skin tightening, they are trying to mention which characteristic feature of scleroderma? Leather-like skin. They are trying to mention. So skin tightening is a feature of skin tightening means leather-like skin. They can also give you skin induration or redness over the skin. That is same scleroderma mein hi hota hai. ठीक है? Now if I talk about scleroderma, guys, okay, there would be scleroderma is also called as what? Systemic sclerosis. Scleroderma is also called as systemic sclerosis. So by the name it is evident there would be sclerosis or fibrosis at multiple sites. Right? So if there is fibrosis of the skin or sclerosis of the skin, there would be leather-like skin. If there is fibrosis around the mouth, they will mention that there would be pinched mouth. There would be a pinched mouth or pinched pieces. That is called as microstomia. That is called as micro. So the patient is unable to open mouth widely. That is called as microstomia. There would be fibrosis of the salivary glands also, and therefore saliva production goes down. Bad breath is seen. That is called as halitosis. That is called as halitosis. Due to deficiency of saliva, the patient can also have oropharyngeal dysphagia. Okay, that is difficulty swallowing because saliva helps us swallow the food, right? Important. Sorry. Apart from that, on over here you can see there would be pitting scars on the volar aspect of the finger, and these pitting scars on the volar aspect of finger are called as sclerodactyly. They are called as sclerodactyly. So pitting scars on fingers are called as sclerodactyly. Okay, all of these features would be seen. Along with there would be esophageal dysmotility. There would be esophageal dysmotility. And as there is esophageal dysmotility, again the patient will complain of dysphagia in the patient. Okay, there would be again dysphagia in the patient. No issues with this. A question classically mentioned किया था, the dry biscuits or wafers usually stick to the palate of the patient. It is seen in cases of systemic sclerosis or scleroderma. ठीक है? अगर ऐसा कोई केस है तो आँख बंद करके scleroderma मार सकते हो. ठीक है? No issues with this. Now scleroderma can either be systemic or it can be limited also. In cases of limited sclerosis or limited scleroderma, please tell me the features are remembered as crest. The features are remembered as, so limited scleroderma is also called as crest syndrome. Limited scleroderma is also called as crest syndrome. C goes for calcinosis cutis. C goes for calcinosis. So there would be calcification within the skin and chalky plaques would be seen. Okay, C goes for calcinosis. C for R goes for Raynaud's phenomena. R goes for E goes for esophageal. E goes for esophageal dysmotility. E goes for esophageal. E for S for sclerodactyly. S for petting scars on the fingers. And T for dilated blood vessels in the skin known as telangiectasia. Okay, T for no issues still here? I hope so. Now, once you have made a suspicion that the patient is having systemic sclerosis or limited sclerosis, investigation of choice would be antibodies, right? So, investigation of choice for systemic sclerosis is anti-topoisomerase. Which antibody? Anti-topoisomerase for which antibody for systemic sclerosis? Which antibody for limited sclerosis? Anti-centromere. Which antibody for limited sclerosis? Anti-centromere antibody. No issue still here? Sorry guys. What is the drug of choice? What should we get? Aspirin de sakte ho. Along with that, autoimmune. Steroids can be given to yes. Steroids can be given to this patient, definitely, right? So steroids are given. If you need to avoid steroids, then you can give some other drugs like azathioprine, okay, which are steroid sparing agents. Okay, no issues with this. I hope so. It is fine. Okay. Now, antibody for systemic sclerosis, antibody for limited sclerosis. A 30-year-old male, young adult male, presenting with low backache and morning stiffness. आँख बंद करके क्या मानना है? Ankylosing spondylitis. Young adult male, low backache, morning stiffness. Ankylosing spondylitis. Here the patient, as I told you, will have morning stiffness for almost 30 minutes to 1 hour, not more than 1 hour usually, right? And here also the morning stiffness will improve on physical activity, right? So here the answer is ankylosing spondylitis. The diagnosis is ankylosing. Which age group is commonly affected? Young patient. Which age group is commonly affected? Which sex is commonly affected? And what is the most common symptom? Low backache. Most common symptom is? No issues with this. Now, the first line investigation would be so definitely if the patient has come to you in the earlier stages, you can perform a MRI because on X-ray again, features would not be seen. But if the patient comes to you in later stages, you can even do a X-ray. And X-ray kiska karoge? Lumbosacral spine, LS spine. X-ray is of lumbosacral spine. Characteristic features. The most characteristic or the most pathognomic feature of ankylosing spondylitis. It is bamboo dagger or sacroiliitis. It is bilateral sacroiliitis, inflammation of the bilateral sacroiliac joints, and that is the cause behind the low backache in the patient. Okay, so the most characteristic feature is bilateral. Sacroiliitis in the patient. No issues with this. Apart from that, definitely due to fusion of the intervertebral disc. Okay, you can see a with spine. Due to fusion, you can see the. And due to calcification of this interspinous ligament, you can see which sign? Dagger sign. Due to calcification of interspinous ligament, you can see. Dagger spine. Okay. Sometimes they also call it as the trolley track sign or the tram track sign. Okay. So all the ligaments are calcified. Therefore, it also appears like the tram track or the trolley track sign. Okay. No issues with this. Ortho से important है. Ortho से ये question आता ही है. ठीक है. What is the investigation of choice? MRI. Investigation of choices again. MRI spine would be done, on which we can see inflammatory changes would be there, or there can be a bone marrow edema in the patient. Okay, there would be a bone marrow edema, but the characteristic feature is bilateral sacroiliitis, which leads to the most common symptom, that is low back ache in the patient. No issues still here? I hope so. What is the drug of choice? Drug of choice. If I ask you the first line management are definitely NSAIDs in the patient, non-steroidal anti-inflammatory drugs. First line management are definitely, but if the patient is not improving on NSAIDs, then we can give biologicals like infliximab. Then we can give biologicals like, okay, so first line are patient not improving, then so if we give two NSAIDs, then also the patient is not improving, then we give infliximab to the patient. ठीक है, biologicals इतने safe drugs नहीं होते and इतने सस्ते नहीं होते, एक ड्रग 35-35 हजार का होता है. ठीक है, so सोच समझ के देना अपने patient. So याद रखो, important. Hyaluronic acid का injection 35 to 40,000 का आता है almost hospitals में. ठीक है. So now at ankylosing spondylitis, as we know, it is HLA associated disease, and which HLA is positive? HLA B27. If any one of you is interested in diagnostic criteria for ankylosing spondylitis, please remember, for ankylosing spondylitis, MRI features should be positive along with one spondyloarthropathy feature. या फिर bilateral sacroiliitis would be present on, like MRI. For diagnosis, please remember, MRI should show bilateral sacroiliitis along with one spondyloarthropathy feature. या फिर the patient should have HLA B27 positivity along with two spondyloarthropathy features. ठीक है, that is the diagnostic. Atrophy of muscles of the usually the gluteus muscles are atrophic. ठीक है, and one test इसका नाम ortho से important है, you need to perform. This is known as the modified Schauber test. The test which is performed is known as the modified. So we will ask the patient to bend down, okay, and if the bending down is not proper, okay, or it is decreased due to the stiffness, then it is classified as positive modified Schauber test. ठीक है, so which test is asked for clinical examination? Which test is performed for clinical examination? Modified Schauber test. No issues with this. Okay, HLA B27 positive arthritis है ये. Okay, it is a HLA B27 positive arthropathy. Other HLA B27 positive arthropathy are, okay, giraffe is a mnemonic. I have remembered it with HLA B27 positivity. J goes for juvenile rheumatoid arthritis. J for I for inflammatory bowel disease. I for when inflammatory bowel disease, that is Crohn's disease or ulcerative colitis, also the patient will complain of arthropathy. That is also HLA B27 positive. R for Reiter syndrome. R for new name of Reiter syndrome is reactive arthritis. New name is reactive arthritis. A for ankylosing spondylitis. A for ankylosing spondylitis. And P for psoriatic arthropathy. P for I hope we are done with this. Then, if a patient will complain of dry mouth and dry eyes usually, okay, patient will complain of dry mouth and dry eyes usually only. Keratoconjunctivitis sicca bolte hain isko. The more likely diagnosis would be as Sjogren syndrome. More likely diagnosis is Sjogren syndrome. In Sjogren syndrome, what is the investigation of choice? The antibodies are anti-Rho and anti-La. Anti-Rho and anti. So which two antibodies are seen in Sjogren syndrome? Anti-Rho SSA or anti-La SSP antibody. No issues. Moving further, a middle-aged patient, this time a female, A middle-aged female presents to you with cough along with breathlessness or dyspnea. Along with this, she has this purplish color or a reddish color lesion involving the cheek and the tip of the nose, not the bridge, but rather the tip of the nose. And here you can see sometimes the nasolabial folds can also be involved. Nasolabial folds can also be involved in this patient, right? This is called as lupus erythematosus. This is called as lupus, and the diagnosis would be sarcoidosis. Diagnosis would be sarcoidosis. A commonly repeated question, sarcoidosis. So please remember, sarcoidosis can have multi-system manifestation, but the most common organ involved is the followed by skin. Okay, most common organ involved is lung. In skin, we can see this purplish lesion usually involving the nasolabial folds, tip of the nose, and the cheeks. Usually, this is called as lupus erythematosus. What is the difference between malar rash and this? So malar rash does not, never it will involve the nasolabial folds, but this lesion can involve the nasolabial folds. Okay, important. No issues till here. Along with that, the second skin manifestation seen is erythematosum. The second skin manifestation is erythematosum. Then if she is complaining of cough and dyspnea, first line investigation is obviously the chest X-ray. What is seen on chest X-ray? The classical finding or the most characteristic finding of sarcoidosis, and that is bilateral hilar lymphadenopathy. Most characteristic finding is ये X-ray रट लो पूरा, ठीक है? There would be enlargement of the lymph nodes, of the hilar lymph nodes on both the sides. So bilateral hilar lymphadenopathy in a middle-aged female. आग बंद कर सकते हैं. Answer would be sarcoidosis in the patient. Along with that, sometimes you can also see mediastinal lymph node enlargement at times. ठीक है? तो याद रख लेना. Then if I talk about sarcoidosis, sorry, in skin lesions I spoke about, the patient will have lung lesions and therefore the patient will complain of cough, dyspnea, all of that. But all of this is actually due to the presence of, so please remember the CD4 T cells are activated. Which cells are activated? CD4 T cells, okay, due to a previous infection. And due to the CD4 T cells, they will lead to release of interferon gamma. They will lead to release of interferon gamma. And interferon gamma is the main culprit behind granuloma. One liner general fact say. Most important cytokine responsible for granuloma production it is. Most important cytokine responsible for granuloma production is interferon gamma. And this granuloma would be a caseating or a non-caseating granuloma. So in cases of sarcoidosis, which type of granuloma is seen? Caseating granuloma means at the center of granuloma you will have cheesy necrosis. Caseating granuloma is seen in cases of TB. And which fungal infection? Histoplasmosis. Which fungal infection? Histoplasmosis. So caseating granulomas are seen over there. Non-caseating granuloma is a feature of sarcoidosis. Non-caseating granuloma along with colitis. Jaldi. Non-caseating granuloma with diarrhea, abdominal pain, all of that. Ulcerating or Crohn's? Crohn's disease. Non-caseating granuloma are also a feature of Crohn's disease, not ulcerative. याद रख लेना. ठीक है, no issues with this. These non-caseating granulomas can be present in various organs like the lungs, the liver. Therefore, there would be hepatomegaly, splenomegaly, anything can occur in the patient. Okay, no issues with this. If I talk about the granuloma, this granuloma, I hope all of you are quite aware. Granuloma, usually there are multiple macrophages. There are some giant cells, and there is lymphocytic infiltration around that. Right. So this is what is called as granuloma. But in the macrophages, we can see these basophilic intracytoplasmic bodies. And these basophilic intracytoplasmic calcified bodies are called as Schaumann bodies. These are called as, so basophilic bodies are called as, but the intracytoplasmic star shaped or stellate shaped eosinophilic or pinkish color bodies These are called as the asteroid bodies. These are called as the, so star-shaped are, whereas blue-colored are, pink-colored are asteroid. Calcified are Schaumann. Calcified are, ठीक है, याद रखना. Bodies are no. ठीक है. Then previously we used to do a QIM test. ये बस last time question आया था, though it is absolute. इनको पता नहीं, बीच-बीच में question पूछते रहते हैं. So the absolute test which was done, it was the QIM test. Which test was done earlier? It is obsolete now. What is the investigation of choice? Anybody? Investigation of choice would be a, in sarcoidosis the investigation of choice would be a granuloma. देखना है ना, क्या करोगे? Biopsy. You will perform a endobronchial ultrasound guided biopsy. You will perform a, बोलो तो सही, आलसी हो एक मतलब, endobronchial ultrasound guided biopsy. Okay, how you can perform endobronchial? Because these lymph nodes are almost coming in the bronchus also. So ठीक है, तो वही से ले लो sample. So investigation of choice for sarcoidosis is ultrasound guided biopsy. If lymph nodes are not enlarged, usually they are enlarged only, but if they are not, you can take the tissue sample also, lung sample, liver sample also. Over there you can also see non-caseating granuloma. If I perform a gallium-67 scan, which sign is seen? Due to involvement of lacrimal and parotid glands, I can see the panda sign. Which sign? Panda sign. Why? Gallium-67 scan पे drug of choice for sarcoidosis, steroids. Drug of choice for sarcoidosis. Now last two pathos से important. Granulomas तो देख लियो, उसके अलावा. Now please remember, in sarcoidosis, these non-caseating granulomas which are formed, they are known to activate one enzyme, and that is known as 1-alpha hydroxylase. They activate which enzyme? These granulomas activate 1-alpha hydroxylase. 1-alpha hydroxylase is the rate-limiting enzyme for vitamin D synthesis. It is the rate-limiting enzyme for. So vitamin D levels are high. And therefore serum calcium levels would also be high. So hypercalcemia is seen. Increased serum vitamin D levels are also seen. And which enzyme is elevated? ACE enzyme is also elevated in the patient. Which enzyme is elevated? So what three things are elevated? First is vitamin. Second is serum. And third, which enzyme? No issues with this. Moving further. Vasculitis start karo. 70-year-old female, feverish, complaints of unilateral temporal headache. More than 50-year-old patient complaining of unilateral temporal headache and fever. On examination, a cord-like structure is seen. Structure is seen on the temple. Most common vasculitis in adults is? अगर GCA option अगर दूसरा ऑप्शन में है idiopathic cutaneous vasculitis, then mark it as first choice. ठीक है? Most common vasculitis in adults is idiopathic cutaneous vasculitis, followed by giant cell arteritis, followed by no issues with this. Most common vasculitis in children, if they ask you, HSP, Henoch-Schönlein purpura. Most common vasculitis in children. Most common vasculitis in Asian or Indian children. Kawasaki. Most common vasculitis in Asian or Indian children. Kawasaki. No issues with this. Now, here if the patient complains to you of unilateral temporal headache, it is the most common symptom of giant cell arthritis. The diagnosis is giant cell arthritis. It is also called as temporal arteritis. It is also called as, okay, why it is called as temporal arteritis? Because the most common vessel affected is the superficial temporal artery. Most common vessel affected is therefore the most common symptom would be unilateral temporal headache. Most common symptom is if I ask you the most specific or the most characteristic symptom, then your answer would be right, jaw claudication. Most specific symptom is okay, because please remember this superficial temporal artery will also supply the temporomandibular joint. If there is ischemia to the temporomandibular joint, there would be jaw claudication or pain while moving your jaw. Okay, no issues with this? I hope so. Okay, on examination on the temples, you can see a cord-like structure. What is the investigation of choice, anybody? Investigation of choice is previously biopsy was not recommended or biopsy was contraindicated because like we used to damage the structures also, other like the whole vessel. But now we have some advanced method with which we can only take a vessel wall biopsy. So the investigation of choice is and in all the layers of vessel wall you can see giant cells. You can see. So here you can see the lumen is decreasing in size, and in between there are presence of these giant cells, and there is lymphocytic infiltration also. Okay, no issues with this. So अगर giant cell बोलते हैं vasculitis में GCA तुम्हारा diagnosis होगा. What is the drug of choice, guys? Drug of choice are steroids. Drug of choice are most common age group more than 50. Most common age group, most common sex females में common है ज़्यादा. ठीक है, more common sex females में थोड़ा सा slightly common है, otherwise it is almost equal. ठीक है, no issues with GCA now. It is a large vessel vasculitis. Then talking about the next large vessel vasculitis, and that is this one. A 30-year-old Asian patient or male presents with arm claudication. That means whenever he starts writing, there will be pain. On examination, unequal BP was noted in right and left arm. Diagnosis is Takayasu arthritis. Diagnosis is. So this is the most characteristic feature, guys. Unequal blood pressure in the right and left arm. I talk about that. Please remember, if they ask you the most common vessel affected in Takayasu arthritis, it is the left subclavian artery. Most common vessel affected is the left subclavian artery. And here the lumen of the left subclavian artery would be narrow. Therefore, the blood supply to the left arm would be decreased, and therefore the blood pressure in the left arm would be low. Blood pressure in the right arm would be high. So unequal blood pressure in right and left arm would be seen. No issues with this. So yaad rakhna, most common. Other vessels can also be affected. Yaad rakhna, the other vessels of the branches of arc of aorta can also be affected. It can either be the right subclavian artery also, but the most common is definitely the left subclavian artery. The most common complaint would usually be arm claudication. There would be pain on writing or pain on using the hand. Okay? Now please tell me, unequal blood pressure in right and left arm is usually seen in three conditions that you need to remember. First is Takayasu arthritis. First is. Second is coarctation of aorta. Second is coarctation of. So तुम बोलोगे coarctation of aorta. In coarctation of aorta, usually there is increased blood pressure in the upper limbs and decreased blood pressure in the. So unequal blood pressure in the upper and lower limbs is seen. Yes, it is usually seen in cases of post-ductal variety. It is seen in cases of unequal blood pressure in upper and lower limbs, post-ductal COA. Unequal blood pressure in upper and lower limbs, unequal blood pressure in upper and lower limbs, whereas unequal blood pressure in right and left arm, pre-ductal COA. Unequal blood pressure in right and left arm, unequal blood pressure in right and left arm, pre-ductal, that means over here there is somewhere coarctation of aorta. Okay, no issues with this, guys. Okay. And the last one is supravalvular aortic stenosis. Last one is supravalvular aortic stenosis. अगर ये भूल जाते हो तो कोई दिक्कत नहीं, but the first two are important. First is unequal blood pressure in right and left arm. First is. Second is which variety? Which variety of COA? No issues with this. Now Takayasu arthritis, as I told you, there would be ostial or lumen narrowing. Therefore, the patient will have arm claudication. But there would also be narrowing of the renal artery. And if the renal artery is narrowed, there would be activation of the renal artery narrow hoga. GFR will decrease. And if GFR decreases, activation of RAS. And therefore, there will be increased levels of renin, which will cause hypertension in the patient. And therefore, it is called as renovascular hypertension. What is seen? So, most common cause of renovascular hypertension in Asian patient is most common cause of renovascular hypertension in Asian patient is but most common cause of renovascular hypertension worldwide is fibromuscular dysplasia. Most common cause of renovascular hypertension worldwide is fibromuscular dysplasia. One liner hai, aa chuka hai pehle. ठीक है, no issues till here. Now, what is the treatment of choice? Anybody? Steroid बाद में देंगे. BP के लिए बताओ पहले. ACE inhibitors would be given. Okay, for hypertension we will give ACE. And again, it is an autoimmune condition, so we will give steroids to the patient. We can give steroids to the patient. No issues with this, I hope so. Okay, right? Next, moving on to most favorite. Now, the case will likely present to you a 5-year-old child. Okay, a 5-year-old child presenting to you with fever for more than 5 days. And he also complains of chest pain. On ECG, there are features of myocardial infarction. So myocardial infarction in such a small child, the most common cause is Kawasaki disease, right? So please remember, on ECG, if I see MI changes in a very young child around 3 to 5 years old, the most likely diagnosis would be, and as we know, Kawasaki disease is the most common type of vasculitis in small children. Or Kawasaki disease is the most common type of vasculitis in Asian children. Okay, it involves which? Large, medium, small vessels? Medium vessels. It involves mainly the medium-sized vessels. And Kawasaki disease can be remembered by which features? Cream features. So for diagnosis of Kawasaki disease, how many days of fever is mandatory? More than 5 days. How many days of fever is mandatory? Along with the cream features. C goes for conjunctivitis. C goes for R goes for rash. R goes for E goes for edema and erythema. E goes for edema and redness and swelling. E goes for edema and erythema and A goes for lymphadenopathy. A goes for this lymphadenopathy in Kawasaki is unilateral or bilateral? It is unilateral cervical lymphadenopathy. So lymphadenopathy in Kawasaki is and M goes for mucosal involvement. Which tongue? Which tongue? Which tongue? So again, I will have the same scenario. Okay, again a small child presenting to you with fever along with strawberry tongue features. Apart from that, the child also has rash on flexular areas. There are fascia lines which are seen, right? But lymphadenopathy is unilateral or bilateral? Bilateral cervical lymphadenopathy. Which type of lymphadenopathy? Bilateral cervical lymphadenopathy. The characteristic diagnosis would be, characteristic diagnosis is scarlet fever is caused by which organism? Streptococcus pyogenes. Scarlet fever is caused by? Scarlet fever is caused by? So group A beta hemolytic streptococci. सबसे पहली स्लाइड थी ये इंटीग्रेटेड की, ठीक है? So it is group A beta hemolytic streptococci or strep pyogenes is the cause of scarlet fever. Okay, so first of all there would be fever, mucosal involvement in the form of strawberry tongue. There would be a rash, and this rash they will describe it as sandpaper consistency. कैसी consistency होगी? Very rough rash is there. Okay, it will have a sandpaper consistency. And which type of lymphadenopathy? Bilateral lymphadenopathy. Which type of lymphadenopathy? Unilateral lymphadenopathy with all these features is Kawasaki. Unilateral lymphadenopathy with all these features would be Kawasaki disease. Kawasaki disease ka most common complication would be, most common complication of Kawasaki is, most common complication of Kawasaki is, no issues with this, anybody? Now, what is the, sorry. Now, what is the treatment in cases of Kawasaki disease, guys? Drug of choice is? Drug of choice would be IV, IG. Drug of choice would be IV, immunoglobulin. Drug of choice would be IV. एक मार्क करना है, एस्पिरिन नहीं मार्क करोगे. Drug of choice is IV. Drug of choice is IV. Along with that, definitely we can give aspirin to the patient. Only indication of aspirin to be given in children is, only place where we give aspirin to the children is, otherwise aspirin can lead to a very important side effect that is known as, also called as Jamshedpur fever. No issues with this Jamshedpur fever. There would be some hepatic manifestations along with fever. Jaundice hoga patient में. That is Reyes syndrome. Next, क्या हुआ? Any issue? अच्छा, देखते बता रहे हो. In cases of Kawasaki, minimum more than 5 days. Scarlet fever, it can vary. It can vary from 2 days till 7 days also. ठीक है? तो scarlet fever में ये diagnostic नहीं कि fever कितने दिन का होना चाहिए. Kawasaki में it is for sure it should be more than 5 days of fever. ठीक है? इसीलिए fever is not a differential criteria in strawberry tongue. Differential criteria है 2. First, unilateral cervical lymphadenopathy, Kawasaki. Bilateral cervical lymphadenopathy, scarlet fever. Rash, अगर वो rash is smooth, Kawasaki. Sandpaper या rough consistency, scarlet fever. ठीक है? या facial lines भी देख सकते हो तुम flexures पे usually. Child presents to you. The most common vasculitis in children is, most common vasculitis in children is Henoch, Schonlen, Purpura. Most common vasculitis in children is Henoch, Schonlen, Purpura. The child was brought with abdominal pain and arthralgia. So these are the characteristic symptoms. ये भी एक सरकारी question है, repeated multiple times. ठीक है? So the patient presents you with abdominal pain along with arthralgia and purpuric rash. Okay, purpura means what? Petechiae, a non-palpable bleeding spot, but purpura are palpable bleeding spot. So palpable bleeding is seen over here. You can see these purpuric rashes, mainly involving what? Mainly involving the buttocks and the lower limbs. Buttocks and the, so this purpuric rashes on the buttocks and lower limbs in a child. आँख बंद करने से आंसर मार सकते हो. That is acute IDP rule out कर देना. ठीक है? If acute IDP is not an option, then mark it as HSP. Sorry. No issues with this, anybody? I hope so. Now please tell me what is the investigation of choice? HSP. Again, it is an autoimmune condition. It is an autoimmune condition. Henoch, Schonlen, Purpura. Investigation of choice would be Investigation of choice would be, बराबर बोलो तो सही फिर, vessel wall biopsy. Investigation of choice is vessel wall biopsy, on which you can see inflammatory changes in the vessel wall, right? Apart from this, as we know, HSP is a complement mediated vasculitis. It is a complement mediated vasculitis, and this complement is activated by the IgA. So IgA are present in excess. So HSP is a IgA related disease. HSP is a IgA related vasculitis, IgA related vasculitis, IgA related vasculitis, IgA related malabsorption, celiac 2, IgA related malabsorption, IgA related malabsorption, IgA related nephritic syndrome, IgA nephropathy, IgA related nephritic syndrome, IgA nephropathy, IgA related vesicular disease, dermatitis herpetiformis, dermatitis. So here in blood, usually in lab investigations, we will find elevated levels of which immunoglobulin? Elevated levels of, and as it is complement mediated, so low levels of C3, low levels of C3. Complement जब use होंगे, their levels will fall down. ठीक है? No issues with this. Investigation of choice still remains biopsy. Investigation of choice still remains. Investigation of choice still remains. What is the drug of choice? Drug of choice, drug of choice, no issues with this. Characteristic symptoms are purpuric rash where buttocks and lower limbs, and which type of rashes? Pain in the abdomen and pain in the joints. So abdominal pain and arthralgia. Sometimes they can even mention you about hematochezia, that is fresh blood in stool, if the gut vessels are involved. Even joint bleeding can be seen if the joint vessels are involved. Next, if I talk about this one, guys, here you can see a biopsy of a vessel. In the middle, you can see the vessel lumen, and this is the vessel wall. But all the vessel wall is almost filled with the lymphocytes, right? So here we are seeing a fibrinoid necrosis. So fibrinoid necrosis in vessel wall is suggestive of which vasculitis? Hoskins. क्या बोलना चाहते हो? Fibrinoid necrosis in vessel wall is suggestive of. Fibrinoid necrosis in vessel wall is suggestive of. Fibrinoid necrosis in vessel wall is suggestive of polyarteritis nodosa. Polyarteritis nodosa. It is a medium vessel vasculitis, guys. And please remember, here there would be necrotizing vasculitis. Here we will have necrotizing vasculitis. Multi-system disorder. Again, it is a multi-system vasculitis, so any of the vessels can be involved. But which vessels are never involved? Which vessels are never involved? The vessels which are never involved are pulmonary vessels. Vessels which are never involved are pulmonary vessels. So if they mention hemoptysis, directly rule out PAN from the option. So the most common two organs involved would be, there would lungs nahi bola na maine. So there would be kidney involvement. The patient will have kidney involvement. The patient would have, and it will manifest as, along with that there would be heart involvement. Okay, no issues with this. The coronary vessels can be involved, and therefore the patient is at a higher risk of developing either myocardial infarction, and if the brain vessels are involved, then stroke in the patient. Okay, no issues with this. So please remember, PAN, therefore, as it is a multi-system disease, therefore it has a bad prognosis as compared to the others. Okay? Biopsy is the investigation of choice. So investigation of choice for PAN is, on biopsy we can see which type of necrosis, which vessels are never involved, kidney में there would be, heart में there can be, ठीक है, stroke तो brain में होगा, ठीक है. PAN में drug of choice would be, again Drug of choice again. Rheumatoid में ज़्यादा दिमाग चलाओ मत. If you don't know anything in rheumatoid, drug of choice कुछ नहीं पता. If you need to mark something, steroids. ठीक है? A patient has hemoptysis, hematuria. So hemoptysis means lung involvement. Hematuria means kidney involvement. And the below given finding. What is this finding called as? There would be hyperplasia of the gum or inflammation of the gum, and it will appear as strawberry. So this is called as strawberry gums. These are called as strawberry gums are a feature of vaginous granulomatosis. Strawberry gums are a feature of vaginous granulomatosis, is nowadays known as granulomatosis with polyangiitis. Vaginous granulomatosis is nowadays known as granulomatosis with polyangiitis. Okay. Why granulomatosis? Because on vessel wall biopsy I can find granulomas. On vessel wall biopsy I will find vessel wall biopsy पे क्या दिखेगा? The investigation of choice is a biopsy पे हम CN का देखते हैं, तो CN का याद रखो. ठीक है, biopsy पे भी हम CN का देखते हैं along with granulomas. ठीक है. Lab investigation, so it is non-invasive, so it would be preferred. Gold standard would be biopsy. ठीक है, gold standard would be, but investigation of choice is CN का antibody. Investigation of choice is. So now how to differentiate? Vaginous is also a small vessel vasculitis. It will also present with hemoptysis and hematuria. So how to differentiate with vaginous granulomatosis, nowadays known as granulomatosis with polyangiitis. The next is microscopic polyangiitis, and the last one is eosinophilic granulomatosis with polyangiitis. Eosinophilic granulomatosis with polyangiitis is the new name for. It is the new name for Church-Strauss syndrome. Syndrome. Okay, eosinophilic means there is eosinophilia in this patient. Otherwise, the rest of the features are usually same. So here, if I talk about lung and kidney involvement is seen in all of them. CN antibodies, if I talk about CN antibodies are seen in in the other two we can see. Granulomas are seen in. Granuloma is seen in नाम में उनके. In vaginous and Church-Strauss. Vaginous and Church-Strauss, and so therefore they are known as vaginous as granulomatosis with polyangiitis and Church-Strauss as eosinophilic granulomatosis with polyangiitis. But granulomas are absent in microscopic polyangiitis. Asthma would be associated with, this is important. Asthma is associated with Church-Strauss. Asthma is associated with, therefore IgE levels or eosinophil levels are high in. IgE levels or eosinophil levels are high in because it is associated with asthma. Okay, this is how you differentiate it. No issues with this. Investigation of choice for vaginous granulomatosis. And what is the drug of choice? The drug of choice is, if not in option, then steroids भी mark कर सकते हो या azathioprine भी mark कर सकते हो. ठीक है? Cyclosporine would be the last drug I would prefer. It would be the last drug because side effects के profile के हिसाब से हम prefer करते हैं. An Arabian patient. So a patient from the Arabian region or from Turkey or from China, right? Patient presents to you with complaints of recurrent painful oral and scrotal ulcers. So painless oral upper ulcers were seen in SLE. But painful oral as well as genital ulcers. Okay. So either it can be scrotal ulcers in male or vulval ulcers in female. Which type of ulcer? Painful. Which type of ulcer? It would be a diagnosis of Behçet syndrome or Behçet disease. The diagnosis would be Behçet syndrome or Behçet disease. The diagnosis would be Behçet disease is also called as oro-oculogenital syndrome. Behçet's disease is also called as mucocutaneous lymph node syndrome is another name for mucosal involvement. Cutaneous rash, lymphadenopathy is another name for Kawasaki disease. Mucocutaneous lymph node syndrome is another name for mucocutaneous lymph node syndrome is known as Kawasaki disease. Whereas oro-oculogenital syndrome is तो oro-oculo नाम से ही पता चल रहा है oral as well as oro and genital ulcers, oral and painful or painless, painful ulcers. And what is the ocular manifestation is seen? Pain and redness in eyes. And the ocular manifestation which is seen in cases of Behçet's disease is क्या होता है, क्यों होता है? Uveitis. So the ocular manifestation is so here you can see these are the oral ulcers which are seen in this patient, right? So these are the oral aphthous ulcers. Okay, no issues with this. So it is the oro-oculogenital syndrome, painful oral and genital ulcer along with anterior uveitis features like hypopyon. This is characteristic of oro-oculogenital syndrome, that is Behçet's disease. It is also HLA positive, HLA B5 or B51, B5 or B51 or B5 or B. No issues with this. So it would be B5 or B51 positive. What is the drug of choice? Drug of choice would be, so for oral ulcers, usually we can give topical steroids. Okay, for ulcers we can give topical. But for anterior uveitis, steroids are not given because that can lead to corneal perforation in the patient. So therefore, for uveitis, we will give which drug? Steroid sparing agent, that is azathioprine. So याद रखना, ophtha से भी important है. If a patient comes to you in acute episode of inflammation, like acute anterior uveitis, steroids are not given because they can cause corneal perforation. Okay, important. This was a question earlier. Next, last question from Rhemat. A 5-year-old child was brought with fatigue, muscle weakness, and inability to climb the stairs. Gene mutation seen as. So 5-year-old child brought with fatigue, proximal muscle weakness usually. This was a recent question also. The patient will have respiratory muscle paralysis that will cause dyspnea or breathlessness in the patient, and the child will die. On examination, you can see the child from sitting to standing position will use his hand. This is known as which sign? This is known as which sign? Gautam sign. This is known as the when the child wakes up with his hand support. This is known as the Gautam sign. Image came earlier once. Okay, Gautam sign. And Gautam sign is usually seen in a children with proximal muscle weakness and respiratory paralysis. It is due to which gene mutation? Dystrophin gene mutation. Which gene mutation? Dystrophin gene mutation. Dystrophin gene is located on chromosome number. Dystrophin gene on chromosome number. याद रखना. The severe version of dystrophin gene mutation, when the child will present to you earlier, like around 5 to 6 years of age group, with proximal muscle weakness, inability to walk, and respiratory paralysis, then the severe form is called as Duchenne's muscular dystrophy. Severe form is called as Duchenne's muscular dystrophy. But ये option में नहीं था last time, and most of you got confused. I'm not sure why. The milder form, where the patient will present to you around 10 to 15 years of age group with the same symptom, proximal muscle weakness, respiratory paralysis, but later in the age. Okay, and the prognosis would be much better. It would be a case of Becker's muscular dystrophy. The milder variant is called as Becker's muscular dystrophy. It is called as the Becker's muscular dystrophy. Whereas the severe version is called as the Duchenne's muscular dystrophy. No issues with this, anybody? Yaad rakhna. If in case of Duchenne's muscular dystrophy, we can examine the patient, and here you can see there would be hypertrophy of the calf muscle. So this is called as the pseudo hypertrophy of calf muscle. What is seen? What is seen? Pseudo hypertrophy of calf muscle. Pseudo hypertrophy of calf muscles also giving us an appearance of champagne glass. Champagne glass legs या champagne glass. It is usually seen in cases. ये recent question था. Like I got that. Champagne glass pelvis is a feature of achondroplasia, but champagne glass limbs or champagne glass due to hypertrophy of calf muscles is a feature of Charcot-Marie tooth disease. It is a feature of Charcot-Marie tooth disease. No issues with this. Now, this was a question, so बस रट लो ये चीज भले ठीक है. Now, a patient who is 30-year-old presenting to you with Gauer sign. 30-year, 40-year-old patient presenting to you with Gauer sign. Definitely it is to be a likely autoimmune condition, and the patient will have these type of rash over the eyelids, known as the heliotrope rash, known as the, along with that, there would be shawl sign. There would be a redness or rash over the pullover surface. This is known as the shawl sign. Along with these papules, these are known as the Godwin's papules. These are known as the diagnosis would be dermatomyositis. Diagnosis would be. So please remember, if an adult male or female patient presents you with Gauer sign, diagnosis can be. If adult patient comes to you with Gauer sign, the diagnosis can be dermatomyositis, inflammation of skin as well as muscles. Which rash is seen over the eye? Heliotrope rash. Which rash? Which sign? Shawl sign. And which papules over the hand? Godwin's papules. Sometimes they can also mention you about the mechanics hands which are seen. What is the antibody seen over here? एक याद रख लो कम से कम. Anti-Jo1 antibody. Which antibody is seen? Which antibody is seen? Which antibody is seen? Anti-Jo1 antibody. And drug of choice would be autoimmune steroids. Autoimmune steroids. ठीक है? Strawberry. Last हिमायत नहीं करते आज फिर because क्या करना है? या हिमायत basics बता दो बस ये slide. Next वाले हाथ उठाओ. आज वाले हाथ उठाओ. 3 या 4 लोग. चलो ठीक है. I'll discuss it and I'll just tell you about this slide of हिमायत. ठीक है? Normal slide because ये आपकी एग्जाम में. So जल्दी से. So guys, all those online also participate. Strawberry gums are a feature of. Strawberry gums are a feature of. Strawberry gums are a feature of. Strawberry gums is in which vasculitis? Which vasculitis? Which fever? Which fever? Strawberry gallbladder is seen in cholesterosis. Strawberry gallbladder is a feature of. Strawberry gallbladder is a feature of. Cholesterosis of gallbladder. No issues with this. Strawberry or mulberry like nasal mass is seen in rhinosporidiosis. Strawberry or mulberry like nasal mass. Strawberry or mulberry like nasal mass. Strawberry or mulberry like nasal mucosa. Inferior turbinate hypertrophy. Okay, strawberry or mulberry like nasal mucosa. Inferior turbinate hypertrophy, which is seen in case of DNS. ठीक है? No issues with this. I hope so. ठीक है. Lastly, I'll only cover this hematology. Normal values करके ये करके जाएंगे. ठीक है? So now this is the normal peripheral blood smear, and in exam in August, you can believe there was a picture of this one, and most of us would not be able to recognize because हम normal चीजें देखते ही नहीं हैं. ठीक है? So please remember, over here you can see the red color cells with a 1/3 central pallor. They are nothing but RBCs. They are your, so all these abundant red color cells with less than 1/3 central pallor, it is suggestive of RBCs or your erythrocytes. RBCs or your erythrocytes. Okay, no issues with this. Now, if the redness in this RBC is absent, if the central pallor is absent and if the RBCs are completely red, it is suggestive of spherocytes. It is suggestive of spherocytes. And spherocytes, as I told you, they are seen in Children में hereditary spherocytosis. Adults में autoimmune hemolytic anemia. Sharp. Right. Next one. The smallest cells that you can see. The smallest cells on a peripheral blood smear are platelets. Smallest cells are the platelets. Now talking about the WBCs where there is confusion. First, if I talk about the granulocytes, okay, these are three: neutrophils, eosinophils, and basophils. Most abundant are neutrophils. So out of the total WBC, we have 50 to 70% of neutrophils. How many eosinophils? ये याद रख लो यार. So जल्दी से बताओ, what is the normal RBC value? Normal RBC count is you can consider it from 3.5 because females के साथ अगर हम देखें 3.5 till 5.5 million. 3.5 till 5.5 क्या? Million cells per cubic millimeter. What is the normal WBC count? 4,000 to, what is the normal WBC count? 4,000 to 11,000. Normal WBC count is? What is the normal platelet count? 1.5 to, normal platelet count is 1.5 to 4 lakh. No issues with this. Now WBCs, if I say, the most abundant WBCs are neutrophils. They are almost 50 to 70%. 50 to 25 to 30% are lymphocytes. 25 to 30% are 8 to 10% are monocytes. 8 to 10% are then 2 to 6% are 1 to 6% are eosinophils. 1 to 6% are and 0 to 1% are समझ गए? No issues with this. जल्दी से now. So if a WBC you can see over here, it is having a multi-lobe nucleus. So if there is a multi-lobe nucleus, it is more likely to be a neutrophil, because as we know in neutrophil there are 3 to 5 lobes of nucleus. Along with that, in the cytoplasm you can see small granules as well. Okay? But if they are not evident, 3 to 5 lobe nucleus, the cell would be neutrophil. If the cell has double or bilobe nucleus, and pinkish granules, then the cell is a pinkish granules with bilobe nucleus. And if the cell has almost a very large nucleus, so here you get confused. We also got confused over here only. If there is a very large nucleus, it can either be a lymphocyte or it can be a basophil. Okay, large nucleus are seen in both. But the difference is, here in basophils you can see multiple small blue colored granules covering the nucleus, right? So blue colored granules are seen in basophil. Blue colored granules are seen in, and only a large nucleus is seen in, and if there is a kidney shaped nucleus, it is monocyte. Kidney shaped nucleus is a no issues with this. More than 5 lobe nucleus of neutrophils is a feature of which type of anemia? More than 5 lobe nucleus of neutrophil, hypersegmented neutrophil, megaloblastic anemia. Hypersegmented neutrophil is a feature of megaloblastic anemia. Normal hemoglobin is, in males, normal hemoglobin is 14 to 16. Females, it is 13 to 15. So we will write from 13 to 16 grams per deciliter. Anemia would be hemoglobin less than 12 in males, 11 in females. Hemoglobin less than 12 in males, 11 in females, and less than 10 in pregnancy. Less than 10 in नहीं बोलोगे, ये याद रख लेना, important. Now if I say the patient has anemia, okay, either the RBC count is low or the hemoglobin count is low, right? So I will also look for, apart from the hemoglobin levels which would be low, or apart from the RBC levels which would be low, I will also look for 2 other features. First is MCV, that is mean cell volume or mean corpuscular volume, which will tell us the size of the RBC. So if normal MCV is 80 to 100 femtoliters. Normal MCV is if it is less than 80, it is microcytic anemia. If it is less than 80, it is if it is more than 100, it is microcytic anemia. Second thing I'll look for is the mean cell hemoglobin concentration or the mean cell hemoglobin, MCH or MCHC, right? It will tell me about the color of the RBC. If this is low, if MCH or MCHC is low, it suggests your hypochromic anemia. Hyperchromic anemia कोई नहीं होता. Either it is hypochromic or normochromic anemia. जल्दी से I don't have space. Okay, I'll erase this one. Let's see. It's not important. I hope. Percentage याद रखना. MCV और MCV का normal value कितना होता है? Anybody 100 to 80 femtoliter. MCH का 27 to 30 picogram. 27 to micromic picogram. 27 to 30 picogram. Please remember. 27 to 30 picogram. MCHC is 32 to 36 picogram. 32 to 36 picogram. ठीक है? याद रख लेना. Now please tell me जल्दी से. MCV is low, whereas MCHC is also low. So mean cell volume as well as mean cell hemoglobin and concentration is low. It is a which type of anemia? Microcytic hypochromic. Microcytic hypochromic anemia. They are remembered by the mnemonic Sital. They are remembered by the mnemonic Sital. याद रख लो, सीता याद रख लो, कुछ भी. So S goes for sideroblastic anemia. I goes for most common type of anemia. T goes for thalassemia. A goes for anemia of chronic disease. A goes for and L goes for lead poisoning. L goes for so lead poisoning can also be a cause of sideroblastic anemia, so you can just remember CETA also. Next, if I say if the MCV of this patient is high, more than 100 femtoliter, but the MCHC is normal, color is normal, size is increased, it is a macrocytic normochromic anemia. Macrocytic normochromic anemia remembered by the mnemonic Lady Harding Medical College, LHMC. ठीक है? L for liver disease, H for क्या? शाबाश. H for hypothyroidism, H for M for megaloblastic, M for and C for cytotoxic drugs. C for cytotoxic drugs can also be a cause of megaloblastic or a macrocytic anemia. Next, if I say MCV is also normal, MCHC is also normal. So this is a normocytic normochromic anemia. Normocytic normochromic anemia. Mnemonic is R. Last time दिया था. A for aplastic, A for aplastic anemia. Aplastic anemia. Second, you can also remember A for acute blood loss. A for acute blood loss. ठीक है? So A goes for two things. First is second is R for renal failure. R for C for chronic disease. So as we know, in anemia of chronic disease, it can be normocytic normochromic as well as microcytic hypochromic. But the more commoner one would be normocytic normochromic. More common is normocytic normochromic. And lastly, H goes for hemolytic. H goes for all hemolytic anemias except so thalassemia is a microcytic hypochromic anemia and not a normocytic normochromic anemia. Okay, with this, thank you so much. Let's meet in the next session for hemat and endo. Next session mein hum will cover hemat and endo guys. GIT, I will try to cover only the points relevant to medicine. Other points of GIT I'll cover in surgery itself. Okay? No issues with this now? Okay then. And then we'll meet after 30th. That is usually after the last session we'll meet at around 3 or 4 for PSL. General path